Hi, good morning.
Morning. Hello, everyone. Sorry, that was all my fault with the wrong link, but we'll get started in a minute or so once we get everyone in and the panelists up.
Okay, I think it may be because my computer has something wrong.
No. It was all me. There was two meetings in parallel and I picked the wrong 50%.
It's okay.
But we'll just wait for Laurin to join.
Yeah, I try to change my my picture here. Oh, okay, I know. I should. Okay, so you can see me now, right?
Yes, I can see you, Sheuwen.
Okay.
Perfect.
Good morning.
Good morning. There we go.
Okay, Laurin.
Hello, Laurin. We got there.
Hello.
Perfect. So firstly, apologies for everyone. We, like I said a minute ago, we had serious operator error with finding the right meeting link, but we're good to go. So let's get started. So good morning, good afternoon, or good evening, depending on where you're dialing in from. My name's David Provan. I'm with the Safety Science Innovation Lab at Griffith University in Australia. Look, I'm really pleased and excited to be moderating today's webinar, and it's titled A Story of Contrasts, Taiwan versus USA, but also maybe resilience engineering versus high reliability organization theory. And we're going to be talking about national differences and theoretical differences in relation to the current global rolling outbreak of COVID-19. So today I'm joined by Sheuwen and Laurin. Sheuwen Chuang is a healthcare researcher at Taipei Medical University. She's also a resilience engineer and works in part with the OSU lab in the US. And she's also a member of the REA communications team. So thanks, Sheuwen. And Laurin Mooney, registered nurse, healthcare expert, and also spent a lot of time, and there's a lot of expertise in high reliability organizational theory, dealing with uncertainty and ambiguity, and runs your own business, Be Highly Reliable. So thank you to both Sheuwen and Laurin for volunteering your time, and also to Yvonne Herrera, the president of the REA, for her continued efforts to promote these valuable free webinars for our global community. So if you're not a member of the REA, please consider joining. It's a really good value. So like I said, today we're going to explore COVID-19 over the last couple of months, and we're going to explore what we might learn from national differences and also theoretical differences in how we understand how complex systems function. So by way of logistics, the talk's being recorded. So to optimize the audio quality, all of the attendees are on mute. And please don't turn your video on, not because we don't want to see you, but because we want to make sure we don't impact the audio quality due to bandwidth issues. Feel free to post questions during the talk. You can type them into the chat. You can address them to me, address them to the panelists, or address them to everyone. And I'll do my best to kind of ask those questions of Sheuwen and Laurin as we go through. So what I'd like to do, perhaps, Laurin, is start with you. And what I'd really like to start with is what you've seen in the US over the past 2 months, and maybe also what your experiences were personally, even just before the outbreak became obvious to everyone in the US.
Yes, so thank you for having me. I'm excited to share what has shaped me, shaped my response, community response, and hopefully we'll get a taste of what happened at the broader United States level. Nothing like being signed up to represent the United States for response to COVID. Keep me humble. So just remember, this is all through the lens of someone who's absolutely crazy about high reliability organizing, shaped very much by my work in the emergency department and then as an off-shift supervisor. So it was my life spent with the unexpected, 3 huge uncertainty events with family, and then on from there. Okay, so yes, I just want to say that when I tell you this, I want you to know that all of my response to this has been shaped by my training. I am actually very future oriented, so I'm mindless in the moment. I'm actually a risk taker, and I make a lot of errors. So what I'm doing in high reliability is because I need it. So basically, I was going happily along my life when I noticed Dr. Wen Liang, and I saw that they had suppressed his message, and I thought, oh, you know, that's always concerning to me. And of course, being an infection as a nurse, I was interested. And then I watched that hospital be built, and that just was profound for me, because I said, well, this is such a strong signal. So in high reliability, we always talk about weak signals, and are we going to act on a weak signal? And I thought, this isn't weak, this is strong. I've never seen anything like this. And then I saw his face in that hospital bed after he had now become ill. And I saw fear in his eyes. And I said, you know, I don't have data, but I have people acting. I have him saying, look, this is really me. He was holding up his ID. And I said, okay, what do we do? I don't have evidence. I don't have an official line, but I'm seeing things that really concerned me. So I started watching videos from news from other countries and getting those diverse perspectives, and being trained in high reliability. When people said, oh, you know, people are falling down in the streets and people are dying everywhere in China, my training said, don't say that's fake, just stay open. It could be possible. So let's see, then we got a phone call from a family member who oversees maintenance for steel companies. And they were asking, because my husband's a dentist, could we possibly send 4,000 boxes of masks because they weren't going to be able to work. And then that just woke me up personally. And then we realized there were no masks available. So let's see, I'm all into the sense making process, because I feel like that's high reliability's biggest gift, is reminding us how powerful and yet vulnerable and fragile that time is right before and at the beginning of an event. That time when weak signals are first perceptible, what is happening right then, both in your mind or even between minds. So let's say I now say we have a big problem, and being a good citizen, I was going to go out and share my new information with the world, and they were going to welcome it. And I always say, you know, we welcome new information. We say, oh, come on in like a friend, because it's going to be your friend. And I mean, it was just the door slammed in my face. I was particularly concerned, my husband being a dentist, that we have now a potential airborne. I looked at actions on the ground, and I'm like, these Chinese people who are highly intelligent believe this to be airborne. And you could see from the suits. And I said, not only that, I could interpret the pictures. I'm like, these people are on dialysis and this person's on ECMO. Like, are you really looking at these images coming out? So I went out. My husband, he was not at this point ready to hear this, the thought, you know, like, your business is going to have to shut down. I went to the radio station, and they just said, oh, you know, I said, this community is really going to need you. Are you aware of what's going on? Oh, we're just a conduit. Go to the Department of Health. I'll never forget this day. I drove to our local Department of Health, and it was a Friday afternoon, and I'm in a full-blown, you know, the sky is falling, and they were closed because they're closed on Friday afternoons. And the sinking feeling that I got was unbelievable. I went back, I met with our preparedness person and our local nurse now this is for 85,000 people. And there was no concern. And I kept thinking, okay, is something wrong with me? They're like, look, it's going to be like the flu. We'll do the social distancing. And I happen to know that from supervising that hospital, we have 6 ICU beds and 3 ventilators. So somehow for 85,000 people, I felt like, wow, we're not going to be able to get care. I checked in with our financial guy. I got a lecture why was I worried about the stock market? The only people that would listen were my family physician and my mother, who is always open to any impending catastrophe. I can count on her. So our local hospital, my doctor said this is about a week before it was declared the pandemic. They were 2 hours into a staff meeting when she said, excuse me, are we going to talk about the possible pandemic coming? And so the the feeling of everyone being at risk, for some reason feeling responsible. I think that's the nurse mom thing. I went to the grocery stores. Do you understand the risk with the push buttons? What are you doing? And Walmart, Stop and Shop, our big grocery store, they're like, you know, we're getting a lot of emails. I'm like, but what are you doing? And I saw such power, potential power in especially Walmart's ability to potentially shape the course of the disease for our country, and just nothing. So I bought what I could for medical supplies on my own. I bought chickens. I stocked up on food, which I'm now happy about. And but I felt it was a horrible feeling. And the piece that really scared me is the lack of ability to, the pushing away of new information, and the lack of ability to imagine something that's outside of our everyday events. You know, what does that mean moving forward? Because I'm like, this mindset that got us here is still in play. And what does this mean? And I said, what's the next, what am I missing? And I'm like, the next thing's gonna be food. And I'm like, well, this kind of is food. So this is all training. So I'm just, this is 6 years of intense work with that piece of time, which is just a slice. We have to look at safety forward, we have to look at safety backwards, but that moment is powerful. And my hope is that we can just hone our skills in that area.
Laurin, your training as a healthcare professional and understanding that context of the situation, and then your expertise in high reliability organization theory and weak signals gave you the ability to create foresight, and largely then it fell on deaf ears, if that's one way of saying it. And I think, as Dave Woods would say, is as soon as it becomes obvious that you need to make a decision, it's too late. So how do you look for those different signals in the environment? So Sheuwen, do you want to give us an introduction about what you've experienced and seen in Taiwan? Because I think it is quite a contrasting situation, and maybe help us with why you think the response was a little bit different.
Okay, good morning, everyone. And I think this time the COVID-19 happened in Taiwan. The whole society, it seems we have prepared to re-experience a new pandemic. So today, I think I will outline 3 things to introduce Taiwan's experience. First, I will introduce the Taiwan status of COVID-19 pandemic. And then, the second, how Taiwan responds to this pandemic. And especially because I am the resilient engineering, so I try to summarize of the Taiwan's experience in disaster resilience perspective. I use disaster resilience perspective, the term, because I think this time is different from normal day. This time is a kind of a disaster. And although resilience has many definitions, but I look at the literature and do some study in the explosion happened in 2015 Formosa fire. And I think disaster resilience maybe is better to explain this situation for pandemic disasters. So first, I introduce the status of Taiwan's the COVID-19 pandemic. Up to now, from the January to April, we have 429 confirmed cases, and 343 those cases are imported, and 55 local acquired, and 31 that's acquired from a comeback support ship. And so all of them as a 429 case confirmed. And all this case was reported, we categorized there's 2 waves of a pandemic. The first wave starting from January to March 15. And why March 15? Because that is a big change. The lower number confirmed cases before March 15, but after March 15, a large number will increase from 55 to 429. So that's a big gap. And so the first wave from January to March 15, and most cases are from Taiwanese people returned from China, and a few cases are local acquired. So this period of time, we have only less than 60 cases in the first wave. And the second wave after March 15, and then there's many people come back from overseas, from European country, from US. So, and the confirmed cases increased. And so there's two waves, and we have a different different strategy to prevent, to control the spreadings. So the Taiwan's experience from the first wave to the second wave, I like to say, especially in the first wave, we have the SARS experience. The SARS experience made us, including individual, hospital, and government, are very sensitive. And we learned, and there is a signals, that's a first case, or the signals from China. So we learned, so we think we should prepare. So individual people and the publics start to wear masks. So when at the first wave, and we start to wear masks, and we start to hand washing. So that means people are alert to prepare to control this virus. And also at the first wave, especially that's into the second wave, the hospitals, their visit, including outpatients, emergency, and inpatients, the total number are reduced from 10 to 20% in Taiwan's hospital. And that means the publics are thinking we should better not to go to hospital. We made trade-off being uncomfortable illness, and between the uncomfortable illness and being infected. So we made trade-off. So all of this experience we come from the SARS, and because at the SARS in 2003, and those people, we do not know the SARS virus is so strong, so transmissible for people. So there are many people were infected by that time. But this time, we start to protect ourselves. So we'll wear mask automatically. And this, I think most people think that is a very significant protection from the virus at Taiwan. So that is one reason we think we have low confirmed cases. And also the hospital, and they start to reconfigure their patient layout. So the confirmed cases and the suspicious cases, they are in different wall. So people, and especially healthcare people, they know where area is the confirmed case, where area is suspicious, and all are they are isolated. So hospital can control and not be infected for other people. So hospital has prepared to control the hospital acquired infections. So this all from a SARS experience. So people learned how to protect individual, and hospital learned how to protect the control the hospital in acquired infections. And the government also at the first wave, they are sensitive too. They learned when we see the first case from China, and then the first case, the first index case was confirmed in Taiwan. That's a Taiwanese businessman come back from China, and then we, the government, we stopped the direct flight immediately from the Wuhan to Taiwan. So that means people are alert for the flight from China to Taiwan, and the people are alert from contact to the people, the person who come back from China. And so the social society are all alert, all prepared to protect themselves, and the social distancing and the birth control, the hospital-acquired infection control, that we all do differently from usual days. So this is the SARS experience. And the second wave, because we have many people return from overseas, so they are infected. So that gives us another panic. So we say, oh, we may have more people, maybe it's a community infection, but then the government gradually made more restrictions to the people. So up to now, and we have, we follow, I think that's we follow US, we have a social distance and the distance, how long we should keep. And everyone, the mandatory have to wear mask. And we shut down, we closed some night pub. And that's a different in different cities. And we reported some other suspicious cases rather than they are like COVID-19, but they are maybe just a seasonal flu. So we report that cases and we test that case. So the government do more restrictions on people, and so that make the second wave under control. So up to now, we have a slow increase in the import cases, and we have well-controlled local acquired cases. But we're still worried, because now we know there's many people, they are affected, they are infected, but they are there are no symptoms, and so they may can transmit to other people. So that is why the government still asks us to keep social distance and wear masks. That's mandatory, and also more restriction on us. So we are preparing for the third wave. Yes.
I think, thanks, Sheuwen. I think it's fascinating that when we think about how government and healthcare experts and professionals work with the population at risk, so the people who are exposed. And in your story, the fact that people had the experience of SARS in their memory meant that collectively you could create foresight quite quickly. And I think you said at one point that you started to prepare on January the 1st, as soon as the first cases in China, and people were able to understand how to manage that risk. And I think you mentioned the other day to me that you haven't even had any sort of forced lockdown of any venues or locations or activities, because people are able to get the information and able to know how to practice their own social distancing. So I think that's a very different situation to the US and other countries around the world that weren't able to create that collective foresight and stand up and know how to respond early.
Yes, the overall Taiwan experience, I try to explain those experience in resilience perspective. So I summarize those resilience perspective in three categories. The first category is that people are capable of organizing themselves and learning from the past disasters, and then react and prepare well for the future one. So that is one resilience. We can learn, and we can organize ourselves, and we learn. And the second is the people has anticipation, and they can anticipate the future, the risk, so they can prepare what they should do and to cope with the future challenge. So that is the second one. And the third one is the coordination between individuals, between a government and public and private sectors and peoples. So we coordinate well. So that is, I think, the three parts. But all of the three, learning ability and anticipation, and also the coordination, which include the partnership and leadership and the decision-making trade-off. So all of those are, I think, up to now, Taiwan can do because of this disaster resilience.
So just for all attendees, feel free to ask questions as we go forward now, and anything that you'd like Laurin and Sheuwen to expand on or to maybe respond to. So Laurin, when you hear that story of Taiwan and how Sheuwen's described the national response and how she thinks through the resilience engineering lens, what are your thoughts in relation to so the US didn't have the recent collective memory of this type of disaster. So how might we think about how we create foresight and respond early and coordinate in the absence of that collective memory?
That is something we talk about all the time with like training for adverse events with patients. Like, how do we create that? My friend literally said to me, she said, I want foresight without ever having to experience harming a patient. This is what she asked me for. And I do believe it can be created. You have to look at a lot of events, and that takes time. You have to, and then you have to be able to draw it closer, because one of the categories that you'll see people constantly putting an event like this is it's the over there, okay? It's not us. So how do you bring it to it's possibly us? And so I just want to say, and Chuang, last time when we were preparing, you talked about the app that allows people to know where infected people were. And when I really believe we had like a mirror image response. I mean, we couldn't learn because we didn't have it. That's a strong word, couldn't, but we chose not to imagine what would a pandemic be. But then we were blind even when we could see it moving towards us, because we didn't have a mindset that was open, right? And at that point it could have been open. And I think I don't want to make any broad brush statements. There were people who were saying we should do something, but they didn't have the power to act. So there's a problem. And then blind, and then furthermore being so blinded with the inability to test. So when she was talking about we couldn't even get testing barely in the hospitals. Meanwhile, I remember Italy saying, hey guys, want to make a bet your first patient's already in the hospital? And then we started finding that. And so we did commingle patients all the time. So yeah, it's, I'm hoping that we turn a page now, and that we realize I think we were stuck in automatic, everything's just going to be fine. We haven't had a bad event since 9/11.
I suppose it's one of those, it is one of the central questions of HRO theory as well as resilience engineering theory about how we know that our systems are vulnerable to surprise, but how do we think about, I suppose on one thing, what are the possible surprises we could face and how do we prepare specifically for those, but then also how do we have the adaptive capacity that it doesn't really matter if we don't know what the surprise is, we're able to sense it and respond to it as early as possible. We've got a question from Victor that I might read. So this idea of people pushing away new information. So in both of the stories, I suppose particularly in the US, there was pushing away this new information and the effect of the SARS experience. So can we say that sense making is more effective with emotional rather than rational decisions? So I suppose if this collective emotional memory of the SARS experience made people maybe better able to make sense of the situation, as opposed to maybe a situation in the US without that emotional connection to the specific situation, people had to deal with rational facts and logic. So any thoughts on whether we're better sense makers if we from an emotional versus a rational type of connection with the information?
And I think a real case experience has more influence. So although people knows, yes, there is some confirmed case we should take care, but if you did not have such strong experience and make a collectively the memory in the whole society, I think the power, the influence power is not large. So I think the sense making from the previous disaster experience can work for the future support to the future one.
And I think, Laurin, you said I think you made the statement, you didn't have any facts, but you saw the emotion in the doctor who was lying in the hospital.
Yes, and that did motivate me. And I think we have another layer even behind, on top of is it an emotional response? Is it people now, and I've seen this more and more, they want data. Okay, so they want it like somehow quantified and hopefully even peer reviewed before they can act. Well, that's a luxury. I'm like, well, we don't have evidence of this. Well, no, we don't have evidence in the form you want it, but we do have evidence. It just might be visual. It might be someone else's activities. And the wanting of evidence all prettied up in a scientific way, that delayed things like crazy. Like sometimes you just have to say the boat is sinking, and to me, and act. And that slowed us way down.
So there's another question here from Beth on that. When you're talking about facts and evidence and delay, and when we think about high reliability organization theory and particularly about deference to expertise, Beth's asked about the impact that the CDC had on the US response, so the Center for Disease Control. And there's also been a debate, at least in the media, in this part of the world, that the World Health Organization maybe delayed the response because of some statements it made about the initial outbreak in China. So, Laurin, how do you see the CDC impacting the US response?
I think that it will all unfold, but the testing fiasco, when they finally get to the bottom of what the problems were, but our rejection of the World Health Organization test for whatever reason, and even people didn't even realize we were quite a while in before they said, oh, we were just going to do surveillance testing. They're like, we're going to mix all the blood samples together and look, is it in this population? So they were looking, I think, and I believe they were looking through the lens of epidemiologists, okay? They weren't looking through the lens of a physician who had to make a concrete decision about where do I place this patient? So that was a piece of it. And the World Health Organization, I remember just saying, if I hear one more person say, but the threat is low, I'm gonna just go crazy, because it's like, how do you know the threat is low? And in fact, it wasn't low at all. So there's that overconfidence, I think.
Yeah. Sheuwen, do you have any thoughts?
Yeah, I want to give an example, compare two hospitals at their response to the COVID-19 at the first wave, because we still have a few cases reported in the first wave. And there a small outbreak happened in one hospital. And so these two cases, they make the difference how hospital respond to a case that is not, you cannot tell that is the patient was infected by the virus. So the one hospital, the ED physician, they have a patient, they are a taxi driver, and he was sick, and he was reported the illness of flu, the seasonal flu, but he was very sick. And then the ED physician immediately treated him as an infected COVID-19 patient. So they put the protective, the personal protective gowns and the wear mask to treat that patient. And then admitted this patient into negative pressure room. So they isolated this hospital isolated the taxi driver. And so this hospital not to have outbreak by the patient. But the other hospital, and they got the similar cases. A person had a serious flu, symptom like flu. But they treat this patient as a regular flu patient. And so they moved this patient into a general ward and take care as a seasonal flu patient. And then there are 8 persons were infected. But I think that's interesting is after the 8 patients, after this hospital was a hospital acquired infection because of the coronavirus the infected, and then the other hospital, and then give strong support to this hospital. So the outbreak was quickly controlled. So I think that between the hospitals, although one hospital is very sensitive, alert, the other hospital was not at the beginning, but later other hospitals support how to protect, how to prevent further the hospital-acquired infection because of the COVID-19. So, so this is a hospital support, not only individuals coordination. A different hospital, they support each other too.
Thanks, Sheuwen. There's a question from Brian here about whether we see that there's a discernible difference between resilience and high reliability organisations in relation to COVID-19. And this has been a long-running debate. And Sheuwen, you mentioned about learn and anticipate and coordination. And Laurin, we've spoken already about deference to expertise and sensitivity to operations. Do we see a discernible difference about COVID-19, or do we see an alignment between the theories when we think about responding to the current situation? Maybe I'll start with Laurin about how you see resilience and HRO. Do you want to take that one? Sure.
Well, someone said, you know, in the past, I really think that the high reliability piece is it's very much that pre-moment, that anticipation, that those first, the mindset and the actions. The resilience, I would say, well, how do you even know? First, you have to even know you need to be resilient. You can just be going along, you know, a bigger hole is happening and you're not even seeing it. So to me, I see HRO, and this is just my perspective, but as how much can we see? But what high reliability organization? That's the point. The power grid's doing great so far, but you know, we had that horrible. We like to think of the Navy, our nuclear Navy, as highly reliable, and that was very sad what happened on that ship, and we're trying to rectify it. But I think the bigger piece, I mean, to me, we'll quote Beth Lay, my dear friend who's always supporting me, but you know, the role, if you want to work in safety, you have to be a truth teller. If you want people to be safe, you have to tell the truth. And I think that a lot of truth has been lost for various reasons. And so as we move forward, the part with like the CDC and the government and just, you know, worse, I wonder what the cost will be just for the lack of trust that we've lost in the United States. Not just our health, you know, and loss of confidence. And at every turn that we don't speak the truth and seek the truth, we're going to have consequences. I can't tell you what organization responded reliably in the United States to this. That sounds terrible. I think people have been resilient and reliable in pockets, but I can't, in a broad sense, say, well, they were really ahead of the, you know, I can't.
Yeah, that's interesting. The perspective on organisations and where they responded. I think I saw one organisation in Australia that moved to 50% of people in the office one week and 50% of the people in the office the next week, and splitting up every team. And at the time, I was, admittedly, I was like, this is crazy. Like, why are you doing that already? But other than that, I didn't see too much early response. Sheuwen, your thoughts on resilience engineering and HRO theory and thinking through the lens of COVID-19? Do you see much of a difference or not?
I'm not quite understand HRO, but from the resilient engineering perspective, I think resilience depends on building and sustaining the capability to act. So it's a kind of a potentials to extend the current capacity into the capability to support the functions. So I think the resilience may different from reliability organizations. And so it's kind of a capability to act. So it's about what we do and not what we have. So I think the resilience you can demonstrate on behavior. So whether that is reliable or not reliable, and so that part I'm not sure. I cannot say.
That's okay. So Brian, we might leave it at that. Laurin, dive in.
Well, I did want to, if any one of you know my business, my little logo is a meerkat, and I'm going to tell you why. I'm going to read a quote that I think might differentiate a little bit. HROs take deliberate steps to create more complete and nuanced pictures. They simplify less and see more. Knowing that the world they face is complex, unstable, unknowable, and unpredictable, they position themselves to see as much as possible. And I think, to me, it's always been about the glasses you're wearing, because sometimes the capability for resilience, the capability to act is there. I've seen cases where the capability was there and we never even saw it. And in all the cases, not all, most of the cases I just said, they didn't see it. If they had just seen it, they could have acted. So I really think that is a shade of difference. I think there's lots of other overlaps.
Yeah, may I ask Laurin a question about, because we think reliable, that means people do things, we can that reliable. But resilience think you can do some adaptations, you can do some initiatives. That's a totally different from normal operations. But we don't know whether that operation, that adaptation is reliable or not. So this is what I concern.
Yeah, and one thing here's where I see the resilience being a piece of it. People always say, well, what's high reliability? And the whole thing of process improvement and processes and procedures. And of course, the famous quote is, we cannot anticipate all the conditions that will shape someone's work. So process improvement, I always see it as it will get you to reliable, but because of all the unknowns, there's that gap, right? And everyone talks about the gap in a different way, but what happens in that gap? How do you see that gap? How soon do you know you're even in the gap? And then that gap is where the resilience is taking place. But that would be a great, a great other conversation to have about the differences in the, because we're all about improvisation, and adaptation. But you got to know you need it first. And
so I'd like you to describe the way that, and maybe in relation to that very oversimplified debate around HRO and resilience engineering. If resilience engineering is a potential, it's capacity in your organization, it's something you do. And as Laurin described, HRO being really focused on what you can see. So in that regard, maybe the theories or the bits of the theories that don't quite overlap are at worst complementary to each other in how you run a complex system. So then we've got one more question over here from Julia, and then we've got a few more minutes. So if anyone else has got a question, please shoot it into the Q&A area right now. So Julia's asked, how do we get post-pandemic control, or what do you see as a properly phased recovery look like to get back to some sort of adaptive normalcy? So if you are now thinking from a foresight perspective of 1 month, 2 months time, is what does that recovery look like in a controlled way? maybe start with Sheuwen. Maybe they might be slightly earlier in their thinking about recovery. But Sheuwen, how do you see Taiwan will make that recovery?
Yeah, first of all, I think we are waiting for vaccine. That is the big things. I think every country is waiting for vaccine. And so before vaccine can be on the market, and so on the government, I still want to use the resilience perspective. I think that's a coordination between the governments, different sectors, and among the people, among the hospital, any healthcare organization, including long-term care organization. I still think we still keep dealing with in different strategies at a different period of time to the pandemic when situation are changed. So that's I still think resilience can support and by coping with the situation changes. So that is, I think, different strategy, different period of time, different actions.
And Laurin, your thoughts then about the US and when and what that might look like? Because I hear a few states are starting to try to open up down California and right now.
Yes, so there's a couple, someone asked me to look at a video. This was very fascinating. He said, watch this doctor on YouTube and tell me where he's wrong. And what he's saying is, hey, it's not been that bad in California. And he was going through all the statistics and Norway versus Sweden, and this many people weren't statistically significant. Except if they're your mother, then there might have been somehow significant. But the key part is, I think that the variability in how this crazy virus played out, not only in human beings, but in areas, right? And then I think the first thing what we need is a dose of humility, because we've been proven wrong and wrong again. So to boldly say that we know how we're gonna open up when we have done nothing but fail is interesting. This is an interesting piece that just happened when the jails in the United States. So they went in and 2,300 inmates, they tested 2,030. So almost the full 2,300 had antibodies. And of them, 95% had no symptoms. So probably if we could test, we would see all these people. So that would be great in a way, I guess, if the antibodies are gonna keep you safe. So, but we need to be able to see what we're doing. And so the testing, that is gonna be a piece of it. What is it gonna, we struggle with this every day. Like, what does my husband do? How do you open up a dental practice where you're spewing saliva? But I will tell you that the new category is, and so Sheuwen, you said, we're getting ready for a third wave, and you use the word panic. See, that's not, we don't do that. We just get mad that we, I don't want to make a blanket statement, but you were ready. We're now using this bucket, done with it, okay? We feel like, hey, guess what? We had a pandemic and now we're almost through it. And I hope that bucket is right, but I don't know. But everyone feels that, we're now going to come out of this. I don't know. It depends how many people have immunity. So I have no idea. I think we're just going to learn. And one other thing that really was bothering me is, do you know, and I remember watching them apologize for something in Korea, not one person, I have not heard one leader get on, any type of media and say, hey, we didn't get that exactly right. Sorry, everybody. Not one bit of accountability of just, I wish we could have done better on that for you. So I think that's where we need to start to say, you know what, this thing it overpowered us, it outsmarted us, whatever it was. But we need to think about how we think. Sorry, I don't have an answer for the opening, but I have no idea.
I think that's a good answer. I think no idea is a good answer. Laurin, I think it demonstrates that humility that you're asking for in more people, because I don't think we do know. And we might have the question talks about phased recovery, and I think we're going to have this really phase thing of going to open and then having to close back down, and what does that actually look like, and when does it, like Sheuwen said, when does a vaccine come, and is the vaccine effective for all parts of the population? Can people be reinfected? And these questions that we probably don't have great answers to at the moment. Joe's asked a question about how we feel about, like in the US, I think we partially covered it, some of the states opening up too soon, and whether other countries are doing the same. And briefly there, Laurin, you mentioned Sweden, and there's been some media in the last week that Sweden kind of rolled the dice on taking the herd immunity path and keeping their economy fully open. And, you know, we've been seeing, you know, life in Sweden sort of continue on as normal to some extent. Do you want to talk a little bit about what you've seen other countries doing, and maybe Laurin first, what you've seen other countries doing and what you think we can learn from that?
Oh, gee. Oh, can Sheuwen go first? Let me think.
Sheuwen, is there much differences of approach in the different Asian countries? We've heard a lot about South Korea in the media.
Yes, I like to take South Korea as an example. I think they do a very good job in the popular testing. So in Taiwan, we did not have many testing as like Korea. So I think if we have so many testing, do we have more confirmed cases reported? We don't know. So that is a very good comparison, but no one has the time to do this now. Most of us are busy to try to fight how to control the virus spreading, not say comparison, which one is better. I think it's hard to compare.
Yeah, I'd agree. I think testing is sort of a big part of it. And like you said, the more you test, probably the more cases. I have heard another piece of information. I don't know how true. There's so much information going around. I'm not an expert in healthcare, let alone immunology. But I have heard that maybe something like 80 or 90% of people who are exposed to the virus and potentially contracting virus have no symptoms at all and don't even know that they've had it. So that becomes very complicated at a population level. There is a question here from Victor again. It says there's sort of two different approaches that countries could have taken. One is what is maybe the most probable or most desirable, which is this thing from the World Health Organization that, it's only like the flu, only 1% of people will die. Like that's, or the other scenario, which looks at the worst case scenario of what a worst case could look. And it seems that the best strategies seem to be the ones that adopted sort of the second approach, like how bad could this get and how can we respond early and scale back if it doesn't turn out to be like that. And Victor specifically talks about Taleb and black swans. So have you got any thoughts about those two approaches, maybe tying it back to the HRO theory? I'll start with you, maybe Laurin, about, you know, are you better off to take a worst case view of the world?
Wow. Okay. So one thing I want to mention, I did send to Yvonne a handout, and and we could forward it to everyone who's been on. And I did link to the first edition of Managing the Unexpected. I looked at some things that we sort of failed to understand or do in terms of HRO, something for sense making, mindfulness. And then there is an article there. It is the United States in comparison to 5 other countries and sort of the stringency of the government pressure. And we were actually low. It doesn't feel low. I said, we were talking the other day, I said, you know what the problem is? We are faced with 2 bad decisions because we are starting to see, you know, the other end of, okay, what are the consequences of holding everybody in? I can't think of the last time as a nation that we had no good option. So how do you navigate that? And then just, you know, the very painful, well, maybe the young people are out and about. Now we have young people having these horrific strokes. But like I said, the other doctor, you could actually make a case that you could play the numbers lots of ways. We're just not, we are not where we need to be to really have a clear picture. So It almost did remind me of a war where you're like, well, are some people just going to have to lose their lives to, like, we just can't get around this one. It isn't a movie where we can have some amazing superpower in the end other than our best decision making. And I think we're going to have a lot of tragedies in other areas. Matter of fact, our family, extended family, did have a suicide that was probably, you know, related.
It's really, really sad, Laurin. Sorry about that. What I might do is, in the interest of time, we've got a message just through the panelists from Beth as the takeout, maybe the biggest takeout in the contrast between the response in Taiwan and the response in the US is just always have a strong response to weak signals. And I think that's a really good statement, Beth, to perhaps end the case on, because we saw Taiwan's strong response to the first case early. And that idea of strong response to weak signals is probably a great takeout to end the webinar on. So those handouts that Laurin mentioned, Yvonne's just said they are available on the REA website. So I'd like to take the time to particularly thank Sheuwen and Laurin for volunteering to share your open and personal perspectives on this situation and your vast experience with the theories of resilience engineering and high reliability organization. Thanks to all the attendees. The next REA webinar is also this week. I think it's going to be April 30th in the US, which is 1st of May, sort of Australian and Asian time. And that'll be Sydney Decker talking about his book, The Safety Anarchist. So please pass that around your communities and get as many people along to that as we can, and keep the momentum behind these fantastic series of REA webinars. So thanks, everyone. I hope you enjoy the rest of your day or your evening, and look forward to joining you on another webinar soon.
Thank you. Bye.
Thank you.
Thank you so much.
Thank you.